Hi, I'm here with Natalia Spierings this morning, who is a consultant dermatologist, and fantastic to have you here because everybody's always got so many questions about skin and how to look after it and their own personal skin. In fact, you're lucky not to be besieged by everybody in the office because when they heard you coming around, they're saying, "Oh, what about my neck? What about my spots? My friends have sent this picture." But you must get that the whole time.
Yes, yes, and via Instagram and via WhatsApp and via email. Okay, so lots of questions and lots of people sending me pictures.
Sure.
So it's fun, but there's a point at which I can't answer the questions anymore because the picture's not always helpful, or I don't know the person.
And the answer is there. Come and have a consultation.
Yeah, I mean, not necessarily with me, with anyone, but yeah, I mean, if you want my advice, it's probably best if I see you in person. I can't really give medical advice to strangers over Instagram.
No. Okay, but we've got some general questions.
Yes.
Now the first one that came in just this morning, which was an interesting one: are infrared saunas bad for melasma and pigmentation? So not normal saunas, but the infrared ones, which these have the panels that heat you rather than the air, so they're kind of heating you from the inside. And I've been wondering, is that an issue with the heat they generate?
Yeah, I don't exactly know where this kind of questions come from, but I'm assuming it's the heat issue. So, and I think that might come from the idea that there's a vascular component to melasma, which is why some people treat melasma with a pulse dye laser or a vascular laser, as well as, if you're going to treat with laser, like a pigment reducing laser.
Okay.
Though the evidence for that's not great. So I just wrote a systematic review about melasma treatment over the past 10 years, and actually the evidence regarding this whole vascular component isn't great. So I didn't, in my guideline, which I wrote in there, I didn't recommend a pulse dye laser based on the evidence. But I think that might be where this question is coming from. So there's no connection between heat and worsening melasma.
Okay, so is it just all hormonal?
Hormonal and then sun related.
Okay.
Yeah, so the combination of
those are the things.
Yeah, the hormone, like the pregnancy, the pill, and then, but we of course don't really understand the pathophysiology of melasma completely, though we do link it to hormones, though men can have melasma. Okay. So that kind of beats that idea.
Yeah.
But sun is definitely very important with melasma. It obviously makes it darker, and when you're under treatment for melasma, you want to avoid your sun exposure as much as possible.
Okay, so careful management.
Yes.
Terrific, thank you. And now that the weather has all turned nasty, winter skin flare-ups was something. I mean, that's a very general thing, and why I put that on the list was because somebody on the team came in yesterday with a real rashy flare-up, but you just had a look at it and said that's eczema more than, because there's a lot of, is there anything in the usual thing that people think it's winter, there's central heating that dries out the air, that makes skin kick off in some way?
That's only relevant in people who have an underlying history, eczema. So if you have a tendency towards that problem, because people with eczema have epidermal barrier dysfunction, anything that will worsen that, so dry air, which increases water loss through the skin, central heating, and the elements as well, just walking outside with lots of wind and anything that kind of damages your skin,
it all kind of just strips it off.
It increases your transepidermal water loss, because with eczema you already have that epidermal barrier dysfunction, so anything that's going to make that worse potentially
it will worsen it all much more quickly than okay. But if your skin is normal and more or less behaving itself, you might be able to weather that. Okay.
Yeah, normal skin probably doesn't have a problem, but the person who was here, she had it in a very she has it in a very interesting distribution, which kind of reflects the wearing of earrings, and it transpires that she may have like a nickel or cobalt allergy, which probably explains the very localized kind of reaction in that area.
Okay, and that had been enough to make it pick up on her face as well. Wow.
Yeah, it can be, yes, yeah.
Definitely. And with an eczema-related flare-up like that, what would you suggest for treating it? I mean, most people with eczema will have something in their
sort of steroid.
Okay.
In their cabinet.
Yeah.
So yeah, generally, if it's a very acute flare-up on the face, can be very uncomfortable and itchy. So I tend to get these patients to use a high-potency steroid for 1 or 2 or even 3 days maximum at night, generally, because they're quite greasy, but you can use them during the day as well. People will generally avoid using something like Elicon or Dermavate on their face because you're all told not to. But under medical supervision, if your dermatologist tells you, 1 or 2 days, put a thin layer on the affected area, that can quickly settle it down, and then you switch to your maintenance treatment. So I like to use something called Protopic for the face.
Protopic, okay.
Protopic,
Yeah, I don't know that.
yeah, people haven't really heard of that. It's topical tacrolimus. So tacrolimus, and that's a drug used as a tablet in high doses for transplant patients.
Okay.
Because
Okay, let's...
there's a visitor.
Yeah, there's somebody coming downstairs. Would you go and say hi to us, please? Sorry, we can just carry on talking. So tacrolimus, sorry, we were talking about tacrolimus, which is used in transplant patients.
Yeah, orally as a tablet. So when people have transplants, they obviously need immunosuppression to stop their bodies from rejecting the organ.
Yes.
So we start them on oral. Well, I don't do this anymore. So I've worked in transplant many years ago as a junior doctor. But generally, we'd start people on oral steroids, high dose oral steroids, and then transition them to something like tacrolimus, which is a long-term immunosuppressant.
Okay.
Using that as a cream or an ointment is getting you the same effect as a steroid, but without any of those long-term side effects like thinning of the skin, skin atrophy. So it's much safer in a way if you're going to use it long-term. And we need our eczema patients to use some type of topical treatment to maintain their skin in the long run for their face. Yeah. So Protopic 0.1% is similar in strength to Humavate, which is kind of a moderate, like a low to moderate potency steroid.
I know that.
That one's good, but it does. Protopic can sting when you apply it to very inflamed skin. So if a patient comes in with very inflamed skin on the face, I will put them on something like Elicon ointment for max 3 days to calm it down, and then switch them quickly to Protopic, and that will clear it up, without the stinging.
Fab, thank you. That's interesting. That's something people could go to their GP and ask about. Fab. There's a question, one of those difficult, huge, unanswerable, well maybe easily answerable questions about pigmentation. What's the best way to treat pigmentation? Or maybe where do we start?
So to
treat pigmentation?
To start, I would make sure you have the right diagnosis.
Okay.
So we need to know what the cause of the pigmentation is.
Yeah.
And though pigmentation sounds like one thing, it's definitely not one thing. So there's some pigmentations, hormonal pigmentation like melasma. There's post-inflammatory pigmentation. So the first step is, what's the correct diagnosis? Then how do we stop this? Because if we're going to treat it, we need to make sure it doesn't come back. Yes. So if you know what the underlying cause is, or you think you know, then you can try to deal with that as well at the same time. And then the treatment is pretty much going to be similar for all types of pigmentation. The most important thing is staying out of the sun, because that will make it darker. Yeah. And also the treatment to make your skin more sensitive to kind of burning. That's the other reason why. And so the best treatment for pigmentation is going to be a topical treatment. So the gold standard is a combination of a topical retinoid with a skin bleaching agent. I don't like to use the word bleaching.
No, but you mean hydroquinone. 4% hydroquinone.
4%. I go up to 8%.
Okay, and use just for a short period of time hydroquinone?
So I use it in a high strength acutely, so over 2 to 3 months to get clearance. And then I put patients on a maintenance regime, so then I will reduce the concentration of the hydroquinone to the lowest possible and perhaps 3 times a week. But all the evidence points towards the importance of maintenance, especially for melasma. So you can't just treat it, have a go, and then say goodbye.
Leave off. Okay.
Yeah, you need to continue it. And the other interesting one for melasma is the use of oral tranexamic acid.
Yes, no, tranexamic acid. I've heard of this. Yes, and that can really help
with melasma.
Just bring it down and get it under control.
And it's a treatment, but then the newest studies are coming out showing that it's also great for maintenance. But again, that has to be done obviously under medical supervision. But we're not entirely sure what the maintenance dosage should be. But it is extraordinarily effective over a 3-month course. When combined with a topical with hydroquinone and retinoid, to virtually clear. I mean, I get virtual clearance of melasma within 3 months, which most people say, melasma is not curable. Well, it's not curable, but I can make it manageable. So much better. Manageable.
And hydroquinone is obviously prescription only. So what about for people who aren't going to go for a consultation with a prescribing dermatologist? What can they try from the high street? Anything that you'd recommend?
So no.
Okay.
sorry.
Sunscreen to stop it getting worse.
But you don't have to, because because Dermatica does give this product.
Yes.
You can get hydroquinone through Dermatica.
Yes. No, it's Dermatica. This is the company that you founded.
No.
Sorry. No. Okay.
Can't take credit for this.
Dermatica is a company that you have
I'm an association with. I work for them. I'm the medical director of the clinical service. So I make sure that the patient pathways are good and the consultation works and we manage everyone appropriately.
Okay, and what Dermatica is an online dermatology
prescribing
service. So you can send photos or upload photographs. Then you have a chat, an online chat with people about
through a consultation form.
Through a form, okay. But that way you can get at a very reasonable cost. It's like 20 quid.
Yeah, 20 quid. It's $19.99 a month.
A prescription cream sent to wherever. Yeah. So it hasn't got to be hundreds of pounds and Harley Street only, has it? Which is
it's all accessible and affordable. So you can get your retinoid and you can get it compounded with the hydroquinone, which is your ideal kind of compound, and then we can adjust the concentrations based on your response and reaction. So it's way cheaper than getting it on private script, because not only because to pay for the actual cream is about £200. Okay. And if you get it private, you can only get the things in 2 separate tubes.
Okay. So but this is it's
compounding. So Dermatic is a compounding
way of doing it.
Yeah, it's
amazing. Yeah. Okay. But the popular high street things, or would you just prefer not to talk about these because they're not, things like vitamin C, which people say can help brightening, or all the products that come in the beauty pages that they come with various clinical or consumer studies that will show that they've been helpful. Are those worth a try for people?
No.
Okay, thank you. No, I value your honesty. No. I really do because it's too difficult if people get given hope by these things that then don't deliver. Okay, so we'll move on to that. But now another slightly controversial one, which I know wearing sunscreen every day, because I've been banging on about wearing sunscreen every day because that's what I've learnt from most of the skincare professionals I've talked to. But you sometimes say that maybe you don't have to wear sunscreen every day.
So this becomes, I think it's much easier to just give a blanket rule saying everyone should wear sunscreen every day, when in reality, do you really have to? If you live in the UK and it's winter and you get on a tube at 7 in the morning and you leave work at 6 in the evening, do you really need sunscreen every day? Probably not.
I see your point,
even when I work in hot countries, and even then I'm literally, it's like 45 degrees. I don't go outside. I get in the taxi, get out of the taxi, go straight into the clinic, and I'm there all day. So I don't wear sunscreen, and I'm in a hot Middle Eastern country.
Yes.
I have it with me, but I don't put it on first thing in the morning. I actually don't.
Okay.
I don't have a pigmentation problem.
Yeah.
If I had melasma and I was treating that actively, then yes, I probably would.
Or historic sun damage or whatever. Then
or history of skin cancer. Then perhaps, especially if I was in Dubai, then yes, I would. But in the UK, like today, it's very rainy. I didn't put sunscreen on today, but I did walk outside for about 20 minutes. I don't think that's bad for my skin.
Yeah. No, it's refreshing to hear that because I try not to be sort of paranoid about sort of something, but I do just out of habit wear it because I know then I think job done. Anyway, well, thank you. That's
it's not bad to do.
Really interesting. Retinol in light masks. I'm a big fan of these sort of light masks that give you red light and infrared light, small dose for reviving the skin. And a lot of people say to me, but surely you're not still using retinol when you're using that mask. I say, well, I am, because and it would create sensitivity in the skin. And I think, well, only maybe if I used a really strong product and then put the mask on top. But I tend to wear the retinoid as I'm using it at the moment at night, and then do the mask in the morning. And the same with hydroquinone. I mean, it's not going to be a problem, is it?
No, I mean, are you using tretinoin now?
I'm using a tiny dose of tretinoin. Yeah.
So, I mean, in theory, supposedly retinoids increase the skin's susceptibility to burning, though actually, if you do biopsy studies and then put skin under UV light, it actually is like an SPF 15. So then this gets into muddy water.
Sorry, what's that?
So basically, if you use a retinoid, the ink, it actually is protective.
Oh.
And But this, I know. So the reason.
No. My understanding has to be very basic, and I have to think retinoid then protect.
Yes.
But you're saying it could be providing the protection.
Yes.
In theory. Okay.
Yeah. So the reason why we say that, there's two reasons why. So one is that the retinoid is treating photo damage.
Okay. Yes.
Yeah, so why would you then expose your face to the sun if you're actively trying to prevent photo damage?
Okay, yes.
So it doesn't have to do with the biological effect of topical retinoid. It has to do with the fact that we're treating something and we don't want you to make it worse. So, and the other side of that is, from a medical point of view, the reason why it says it in the leaflet, because in the little thing you get for the medicine, because oral Roaccutane does increase your burning.
Yes.
And that is where that rule comes from. Just like we can't prescribe retinoids topically to women who are pregnant and breastfeeding because of the theoretical risk of systemic absorption in the baby, whatever, that kind of thing. That also stems from the use of oral Roaccutane.
Okay.
So the warning overlaps, which doesn't make a huge amount of sense. But because of that, there's all this theoretical stuff, and therefore the drug companies and the prescribers protect themselves by saying, okay, well, if it's that case for oral, we're going to use a topical too.
Okay. Thank you. Goodness.
Which is confusing.
It really is, and the detail is very, very confusing, but it's fantastic to be steered through it like this and to hear the what and the why. No, it really is. And just touching on the point that often comes up, people say, oh, you mustn't use retinol, it thins the skin. And I say, well, is it correct to think that it's refining the skin, it's possibly exfoliating skin, but it's creating stronger, thicker skin below. So it might be possibly thinning the very surface, but actually it's overall improving the skin.
It's a little complicated. So retinols, I don't think really do anything. So we're just going to talk about retinoids.
Retinoids. Now, in the family of vitamin A things, you've got prescription vitamin A, retinoids at the top, retinoic acid, and then further down you have, well, right at the bottom you have retinoids. Well, then you have retinol palmitate things.
Those are forms of retinols which do nothing.
Okay, which do nothing.
To me.
No, because they're even weaker. But retinol needs to convert into retinoic acid before it can be of use to your face, so it's a much lesser dose of it. So, but that's retinol, high street retinols is often where people will start. Yeah. So, sorry, but back to talking about the top level stuff, the strong stuff, the retinoic acid, which often comes in the form of tretinoin, which is
So, all right, so this gets complicated again. So for the first few, you know how you get irritation when you first start using the retinoid? One of the reasons you do is because temporarily, when you initially start to use it, you find that the stratum corneum, or the top layer of the skin, does thin out due to the biological effect of the cream. But that is a temporary effect. So I can't say that it doesn't thin the skin, because actually from an actual physiological point of view, it does, but that's how it works. But over time, that goes back to normal, and as you've said, it thickens the dermis because it increases collagen in the dermis, and so therefore, and therefore
another potential patient for you.
There we go. But so you're correct. So, but the temporary thinning of the skin is temporary. It's part of how the cream works. That's why you get irritation. I think people think that because they get peeling, they think the skin is becoming thinner, but actually that's just a normal skin kind of progression through this new treatment, and then over time everything gets better.
Okay, fantastic. We might pause. So lovely, that's not hugely helpful with the kettle.
Are you filming? I'm so sorry.
Yes, but we can. Could you wait just a couple of minutes? We'll ask one more question, and then you can make your cup of tea.
Yes.
Are we still going? Fantastic. Okay. Acne and acne scarring. I know we could talk all day about this at different ages. Are there simple strategies that people with acne can start before they go to a dermatologist? Perhaps what would be 2 or 3 basic things that they should think of? Can we reduce it that much? Yeah,
absolutely.
Thank you.
So first step is to treat your active acne.
Okay.
So I don't do active acne scar treatment until I know the acne is under control.
Okay.
So that's my first step. So that's what I look at first. How active is your acne? Once that's under control, then you can start looking at, and also once the inflammation is down, because often people who have bad acne have a lot of inflammation in the skin, they see a lot of redness, and that's what they think of as acne scarring.
Okay.
But if we tone all that down, treat that underlying inflammation, and then look at the skin, often patients find that it's not as bad as they thought.
Okay.
Then if you're left with dermal scarring, which is kind of the pitted scarring,
deep ones,
then it depends on how bad that is. So over time, using a topical retinoid is your mainstay of treatment. So always come back to the same thing.
With active acne,
you can still use it.
So going back to the active acne, how do you start to get that inflammation under control and bring down the active acne?
So it depends on how bad it is. And on the patient. But my favorite treatment for active acne is going to be oral isotretinoin.
Okay,
it's fast-acting. Roaccutane works. It's safe. It's fast-acting. I know it's going to get my patient from A to B in a relatively fast amount of time with minimal work on their part. You know, you take a capsule method.
And I know we've talked about this before. You said there were some interesting studies, what do you call them, sort of meta-studies?
Meta-analysis and kind
meta-analysis that have looked at, because the thing with Roaccutane that people always come up with is the link to low mood and the dangers of that. But you said, what was it that these studies showed?
So it showed that there was a 20-year retrospective analysis of all the reported psychiatric events on the use of isotretinoin in the United States. And they found that compared to so this is a very brief summary of this massive study, but basically the underlying idea was that the incidence of mental health problems in that population was actually lower than the baseline population.
Okay, interesting.
Which is
so
interesting.
it didn't appear to be causing or increasing it. Right, okay. So I think we could look these things up online. I can probably link to it below the video. And so first, oral vitamin A for Roaccutane would be your first protocol to bring that under control, and then for the scarring that's left, would you go for something like microneedling, or?
It does depend on how bad it is. So microneedling is not bad; it can be helpful, but you would never microneedle active acne. Obviously.
No, for sure.
So yes, you can try that. It's not fantastic, but it can be helpful. If it's very mild. Obviously, combine this with topical retinoid over the long term will be helpful.
Okay.
Hydroquinone can be great for the dark spots. I sometimes individually remove very bad ones. So if there's very deep pitted scars, a very small punch excision of a little one on the cheek will make it smooth again.
And what, the skin regrows?
Yes, so you bring it to because the problem with acne scarring, the problem is that it's the way that light reflects off the skin.
Yeah.
So smooth skin, obviously, it's nice and smooth, light reflects beautifully.
Back.
Exactly.
Yeah.
With a crevice in the skin, you see that light reflection. That's the problem.
Yes.
So if we take away that crevice and make it smooth again by bringing the edges of the skin together, removing the little scar, bringing the edges together, and making a little flat area, you will no longer have that light.
Okay.
So the light reflection, if you will. So with individual kind of box scarring, I can remove each individual scar. You can do subcision too. So if they're very deep, I would first go in and just release the tethered scar tissue that's holding
so that
the
it
scar
can
down. So
rise back up.
Do that first, then look about a month later, see where the pits are, then start to remove those. If you don't want to go down that route, you'd rather do a one-shot blast, a CO2 fractional ablation.
Okay, which is quite hardcore, but that
hardcore,
will do the trick.
Even an erbium-YAG fractional ablation, which is less hardcore but still pretty intense, can also do the trick. So a resurfacing.
Yeah,
it can be great.
So a proper dermatologist, consultant dermatologist, will have a lot of tricks up their sleeve.
Yeah, there's a lot of stuff that's not gimmicky, that's well established. But usually with acne scarring, the more intense the treatment, the better your results can be.
Unfortunately true. I think you always want an easy magic bullet, whatever, and those don't always
work.
Exist. Yeah. Thank you so much. Really great to have you around. Really great to talk all this through.
Thank you for having me. Thank you.